Welcome this afternoon. We are here with Ultimate Opinions in Medicine at our lung tumor board. My name is Mark Sosinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm joined by my four panelists. I'm going to have them introduce themselves. I'm going to start with Dr. West.
Hi, I'm Dr. Jack West. I'm a medical oncologist with a focus on thoracic oncology. I'm an associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area.
Hi there, I'm Kristen Higgins. I'm a radiation oncologist at Winship Cancer Institute of Emory University in Atlanta, Georgia. I specialize in thoracic malignancies, and I'm an associate professor and could be here discussing cases with everybody.
Hi, I'm Varun Puri. I'm a thoracic surgeon at Washington University in St. Louis, and I also serve as a professor in the department and the program director for our cardiothoracic surgery residency program. Glad to be here.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center in New York City. I'm also vice chair of education in our department and professor of radiology at Weill Cornell Medical College in New York.
46-year-old gentleman. We're told he has a stage 3 atypical carcinoid. He underwent resection of an anterior mediastinal mass with node sampling. There was some issue about whether this was thymic versus bronchopulmonary. And we're asked if adjuvant radiation and or chemotherapy was recommended. Again, the patient case is shown here. Excellent performance status, presents with chest pain and some shortness of breath, does have type 2 diabetes as a past history, no tobacco, alcohol, or other drug use, really no family history. I'll ask Dr. Ginsberg to tell us whether she thinks this is in the lung or in the thymus.
This is a very well circumscribed anterior mediastinal mass, and we see that there is some infiltration of the fat posteriorly. Mass measures 6 by 8 centimeters. Now, key questions are surgical resectability, and what's been generally shown is that if you lose the mediastinal fat plane between the mass and the mediastinum, that's could mean that there's invasion. In this case, I see a fat plane and don't think that it is actually invading through. The other issue is there vascular invasion? And what we look for is the degree of contact between the tumor and the great vessels. And in this case, again, it looks like it's right anterior to the ascending aorta, but we do have a fat plane between the aorta and the mass. Other things we look for is if there's any pleural disease, whether this has spread pleurally or if there is any pulmonary parenchymal findings. So to summarize it, this is a anterior mediastinal mass, which seems to be resectable with no invasion of the adjacent structures.
So I'm going to ask Dr. Puri to kind of give us his perspective from the thoracic surgery point of view of this CT scan and just how you think through these sorts of patients you see in your practice.
Thanks, Dr. Sosinski. I agree with Dr. Ginsberg because we often spend time with our thoracic radiologists discussing patients where the origin of the tumor is uncertain and it would sort of somehow change the operative management of these tumors. So I would approach these things differently if the diagnosis were a primary mediastinal neuroendocrine tumor or an atypical carcinoid versus a pulmonary carcinoid. And as you know, the mediastinal or thymic carcinoids are exceedingly rare tumors, while tumors or similar tumors are far more common in the pulmonary parenchyma. Obviously, if this patient has a lesion which is resectable, and the treatment for both lesions, which is whether a thymic or a pulmonary atypical carcinoid, is resection, being the sort of the backbone of any therapy in patients who are resectable. Essentially what one would have to do is how does one plan the resection? When a tumor is clearly located within the lung parenchyma, then a standard approach, either a minimally invasive or an open approach, depending upon the complexity of the tumor itself, what is involved, would be taken. in this particular situation, the mass resides posterior to the sternum and is adjacent to several mediastinal structures. So one could take an initially minimally invasive approach, likely from a right side, either thoracoscopic or robotic assisted for evaluation, but it's quite likely that this would eventually require a stenotomy or a hemistenotomy to resect the tumor. Of note, things which Dr. Ginsberg pointed out, what is the relationship of the tumor to mediastinal structures? And in this case, it does look like the tumor would be clearly separable from the aorta. I would suspect that one would take some pericardium, which would be the posterior boundary of the mediastinum in this particular location, along with the mass itself. Additionally, one would have to assess whether the lung parenchyma is involved, and it's adjacent to the medial aspect of the upper lobe of the lung. And if the lung parenchyma is involved, then one makes an intraoperative assessment as to where does the bulk of the tumor lie. If it looks like it's within the lung parenchyma, then I would consider doing a lobectomy along with mediastinal lymph node sampling or mediastinal lymph node dissection. And that can be done from an anterior approach, which is either a stenotomy or a hemiclamshell kind of approach. Or if it looks like it's primarily within the mediastinum and there is some abutment to the upper lobe of the lung, then one would consider doing negative margin resection without doing a formal pulmonary resection. So maybe take a wedge of the lung out without doing a formal lobectomy if the tumor looks like it's primarily a mediastinal mass and not really a pulmonary tumor. Of note, if this is a pulmonary tumor, then close attention has to be paid to doing a lymph node assessment and lymphadenectomy at the time, because as we know that adjuvant treatments for typical or atypical carcinoid tumors really do not have, they are much less developed than for lung carcinoma, which is standard lung carcinoma or non-small cell lung carcinoma. But the other thing of note is that that this particular tumor doesn't have any structures adjacent to it, which would necessarily need to be removed other than lung. But when we look at margins, so that we also assess that with the pathologist. In a standard lung parenchymal resection, you clearly have planes that you need to preserve and obtain a negative margin. And you often will be given a length of negative margin. Say you have a 5 centimeter margin between the edge of the cut bronchus and pulmonary neoplasm that you're resecting. But when you're removing tumors from the anterior mediastinum, what you have is the mediastinal pleura and fat. So there really aren't structures which will provide you with, say, a 3 centimeter or a 5 centimeter, so a very large margin, which often makes us feel comfortable about the negative margin status of any tumor. So these mediastinal tumors are somewhat tricky, and so we have to have a close cooperation and sort of conversation with our assessing pathologists to figure out whether the margin is negative, close, or positive.
So in this case, it seems that there's a high level of confidence that this doesn't seem to be invading any vital structures there in the middle part of the chest. I guess the question I have is, how confident can you be in those findings on the CT scan? In cases where it's not clear like this, is there a role for MRI to help you define the anatomy, or what are your thoughts there?
Dr. Ginsberg?
Unfortunately, as Dr. Puri knows, we're not that accurate. And oftentimes we may overestimate invasion. And then when you go in, you see that it is indeed resectable because it's so close to the vessels that, as I mentioned, you lose those fat planes, but really the tumor does come off. So we're not accurate. MRI does not really help out with this. Basically, you just have to go to the surgery. We've tried to look at we're currently looking at other ways like radiomic features and other predictors, and we just published something this month on that, if that helps with resectability. But right now, I think surgery is the ultimate answer.
And to add to Dr. Ginsberg's fine points, is that we looked at our own institution, and many years ago, we published data about what portion of the circumference of the aorta is an abutment. At that point, we found that if more than a third of the circumference of the aorta is an abutment, then there's a more than 50% likelihood of the tumor actually involving the adventitia of the aorta. The other thing that Dr. Ginsberg hinted at is MRI. There are studies which look at dynamic MRI. So that MRI where there is respiratory variation, and they will look at movement of the tumor along with blood vessels or independent of the blood vessels along with in the respiratory cycle. So for the descending thoracic aorta and pulmonary neoplasms, there is, I would say, a mild degree of certainty that one can have if the tumor moves with respiratory variation and the aorta is relatively fixed in the descending aorta, while for the ascending aorta, that unfortunately doesn't really help us very much. And I agree with Dr. Ginsberg that that when we perform surgery, then there are times that one can resect tumors in what's called a subadventitial plane. So you go into the very outermost wall of the blood vessel that is involved, and you can resect that. Also in tumors where we think that it is extremely important to have a negative margin and surgery remains the primary modality of treatment, then in that situation, obviously considering the patient's performance status and their overall medical condition, one would resect the major blood vessels. It's rather uncommonly done for non-small cell lung carcinoma, but for other tumors of the mediastinum, or say, for example, in a carcinoid, where it's important to get negative margins, then one would consider resecting a blood vessel if it's necessary.
So you had mentioned your approach. We're told here just last month, apparently the patient had a median sternotomy with resection. Median sternotomy would be your preferred, or what are your thoughts there?
I think that's a good approach. It provides good exposure of the anterior mediastinum, particularly in light of the fact that if one needs to assess the blood vessels adjacent to the aorta, which is adjacent, that's something that would be hard to assess in a minimally invasive approach. And for safety, a median sternotomy is a perfectly acceptable approach, particularly in a patient who has good performance status.
Okay, so the pathology is shown here. Atypical carcinoid, 10 by 7 by 5, several areas of necrosis, very close margins. Dr. Puri, you want to comment on the margins there?
So sort of this was a little bit of the discussion that we already had. The margins, again, I would sit down with my pathologist and we would look over the areas where the margin is closest. If there is no adjacent structure where the margin is closest, for example, if it's the mediastinal pleura that's invaded and the pleura on the other side of the structure is the lung, which wasn't attached to the tumor in the operating room, so that really means the margin was air. So there really is no structure on the other side of that mediastinal pleura that needs to be resected or which was involved by the tumor. So if that's the case, then a small margin, which it looks like it's a millimeter margin, is acceptable. If, however, if this was adjacent to a structure where the tumor was sort of peeled off, then it would be important to see if there were biopsies taken from the other side. For example, if the pericardium was the structure on the other side of the tumor, whether the pericardium was resected or not, whether any biopsies were taken for frozen section analysis or checking the margins from those biopsy sites.
And what about the fact that no lymph nodes were submitted or present here?
So from this description, it appears that this was primarily a mediastinal mass and not a pulmonary mass. So in that situation, for pulmonary neuroendocrine carcinomas or atypical carcinoids, it is relatively well accepted that formal lymph node assessment needs to be performed. However, the rarity of mediastinal carcinoid tumors makes it such that there are no clear guidelines for this. Okay. So I'm not sure if a specific comment can be made about that.
Okay. Okay. All right. So we're told then post-operatively the patient has a CT scan. Dr. Ginsberg, you want to just comment on a CT scan done so quickly after surgical resection?
I mean, probably not usually necessary. You know, this close to, it's unlikely that you recur so quickly, and you do have some post-operative changes there, which may make it a little bit more difficult to interpret. So that's not the usual way, but in this case, fortunately, it was pretty clear that it was just post-surgical changes and there was no residual disease.
Okay, thank you. So the question we're asked to address is the question of adjuvant radiation and/or chemo be recommended for this patient. So let's start with Dr. Higgins and have her discuss, is there any role for adjuvant radiation in this patient?
So, as Dr. Puri had mentioned, the adjuvant treatment recommendations for atypical carcinoid are much less developed than they are for our standard non-small cell lung cancers. Generally speaking, the data that we have for adjuvant radiation for atypical carcinoids is all retrospective database analyses, and there really is no clear direction which way to go. I would say that most centers will give postoperative radiation for a positive margin, and historically, other centers were also giving postoperative radiation for N2 disease. However, now that we have recent data in the non-small cell lung cancer setting in terms of the role of adjuvant radiation after resection for N2 nodal involvement, I would not do that if this atypical carcinoid was in the lung with N2 nodes and negative margins. I would say no adjuvant radiation. And I think in this situation, the margin was negative. I would say that I couldn't tell you that giving radiation is going to definitely improve outcomes. So I would say no radiation.
In this particular case?
In this case, yes.
Yes. Okay. Dr. West, your thoughts on any adjuvant systemic therapy in this setting?
I would largely echo a lot of what Dr. Higgins said about radiation, that we know more about adjuvant chemotherapy by far in the setting of non-small cell lung cancer, and have a real dearth of information about adjuvant therapy for an atypical carcinoid. And what we have is too little to hang your hat on. It's retrospective and somewhat mixed, not clearly supportive of pursuing chemotherapy. This is, with a Ki-67 score of 1%, that suggests that this is not as likely to be chemosensitive. That tends to be what we see with carcinoids. And, so I factor that in when, in any case, when we're weighing adjuvant therapy with conventional chemo, cisplatin or any platinum-based chemo that would be our typical go-to approach, is not non-toxic, not just in the acute period for 2-3 months, but potentially can have harmful effects on in terms of neuropathy or kidney function. There's a reason it's not in the water supply, and so I would be cautious about it. I would say that the nodal status, without having a real yield of the nodes, I'm not sure I'd call it a N0 as much as an NX here. So to me, that's a bit of an unknown, but I would still say I don't know that the systemic risk of relapse is high enough, or the probability of incremental benefit from chemo is that high. I certainly wouldn't go so far as to recommend it. I couldn't based on any evidence. I would say it's reasonable to talk about it with particularly a 46-year-old if they are motivated and fit. I think that it's likely they could withstand the challenge of it. And if they were really eager to pursue just anything that could help so that they never have the regret of what if, then okay, it's defensible, but I would not go so far as to say that I should recommend it. I don't know what your view is here.
Yeah, no, I don't disagree with anything you've said. I guess one of the questions I was going to ask you is, let's say you were in a situation where perhaps maybe the pathology was a bit more ominous, multiple positive nodes, maybe positive margins, these sorts of things. Dr. Higgins, start thinking about, I'm going to ask you the question next, is there ever in a case where you do combined modality adjuvant therapy? But Dr. West, if you were to be convinced that you needed to give chemotherapy, which chemotherapy would you give?
I would give a small cell regimen, probably cisotopicide, which does also have data in some of the original data in non-small cell as well. So I that's what I would lean toward. Yeah.
So Dr. Higgins, and Dr. West, you're not off the hook either on this one. So I'm going to create a much more ominous situation: positive margins, multiple positive nodes. you know, my impression of these atypical carcinoids is that perhaps the greatest place of relapse would be in the mediastinum in that situation. Ever any role for combined modality therapy in the adjuvant setting here?
So I would typically, with a positive margin, I would give adjuvant radiation, and then depending on, you know, the patient, his performance status, we would typically discuss with my medical oncologist if they think the chemotherapy would be a good idea. Certainly for a resection that left behind gross disease, I think in that situation we would add concurrent chemotherapy to radiation. And you know, if for some of these tumors that are, you know, borderline resectable and the imaging is not always 100%, you could sometimes end up with residual gross disease, and sometimes we do have to give concurrent chemoradiation.
And Dr. West, your thoughts?
I would really say that this is, to me, one of the never say never. My general view is, you know, the adjuvant means helper. You know, our primary dictum in medicine is above all do no harm. I don't want to take someone who has received potentially curative therapy and put them in harm's way with something that, you know, chemo radiation, even without the surgery, is one of the more challenging things we do with many patients. When you make a trimodality, even more so. I think it's different with an R2 resection or even an R1 resection, arguably, or very extensive nodal disease. Then I think you do individualize here. When again you're talking about a 46-year-old, I think it's a discussion. You can't rely on data, and so we are left with our best judgment and the motivations of the patient, and individualize. I think 46 versus 76 with or without, you know, significant comorbidities matters in this situation. I wouldn't want to overtreat and harm a patient with our therapies, but I think when you really feel that it's all but a certainty that there's going to be a relapse, you're pushed into a corner and you do what you have to do.
Thank you all. This was a fantastic discussion. I'm going to summarize this case.
Dr. Assistant?
Yes.
I wanted to ask a question which I think may be pertinent for follow-up. And Dr. Ginsberg, how would you think about radiographic modalities for follow-up for this patient?
So we just do CTs with the intravenous contrast, and they're pretty good, and especially with baseline post-op, and you follow it, it's pretty, it's very sensitive at picking up recurrence.
You would not think about a dotatate PET scan or an octreotide scan for this particular individual?
We don't generally do that for follow-ups, and I guess you'd have to have had a baseline to see how much was taken up, because it depends on the somatostatin receptor status and how avid it was on the initial one. So I guess if you had that, you could follow it, but that's not the standard of care at this point.
Okay, thank you.
Only in questionable cases you could after a CT.
Okay, thank you. That's a good question, surveillance. So to summarize this case, we agree with the surgical resection and the approach, and we would, in this case, not recommend adjuvant radiation and/or chemotherapy for this patient.